Hi students, welcome back to the deliberations of Obs and Gynae questions, and now we're going to do the INI-CET questions which came for the November 2022 exam. Good paper, tough and easy ones as usual, a very good mix with the INI-CET paper, and I thought there were a lot of overlap between the topics, which is good because it keeps us on the toes so that we can read all the topics with understanding that each topic has its roots into different other subjects also. So when we have talk about the HPV vaccine, then we should know a little bit about microbiology and we should know something about Obs and Gynae and why the Gardasil vaccine was made. So I like these questions which came. So let's start discussing them one by one. So let's see question number 1. NCCT scan was suggested for a lady of reproductive age. She presented with a history of recent and rapid onset headaches. Which of the following inquiries ought to be made by the radiology technician prior to the scan? So when a woman is getting a exposure to radiation, what are the things you should ask before you do the exposure of radiation by a CT scan or by a chest x-ray, whatever. So it's not what the technician should ask about the reason of the headache. That's for the neurologist to find out, or for the gynecologist who's seeing this patient has to find out. So it's the radiology technician's duty to take some basic history before he does the exposure of radiation to this lady, and that particularly is the last menstrual period. Very simple question, because any woman who is getting exposed to radiation, she should always be very sure that she is not pregnant. So, many times when I send a form for an x-ray and if I forget to write the last menstrual period, the form comes back to me from the technician itself. It's not by the senior consultants of radiology. The technician himself will send the x-ray form back to me to write the LMP, and then only he'll go ahead and make sure that once the woman is not pregnant, she's not missed a period, then only she will undergo the exposure to radiation by a CT scan or by a x-ray. So yes, always find out the LMP of a woman when she's getting exposed to radiation. So the problem with radiation is that anything which is more than the ionizing radiation dose, that can cause problems, and which is around 20 rads. So 20 rads is the one beyond which gross fetal malformations can happen, and up to 5 rads, that is just, one chest x-ray or maybe even 2 chest x-rays is not going to be much problems. But it's better you avoid any x-rays in pregnancy. Having said that, 5 to 10 rads is not a very problematic dose. So more than 20 rads is going to be problematic. And you should also know these conversion units, because sometimes they'll ask you in sieverts, sometimes they'll ask you in millisieverts. So you should know these conversion units. Okay, so there's a list of things which I thought I'll give you, because sometimes they'll ask you what dose at what gestation can cause problems. So 0 to 2 weeks, if there's an exposure of more to 10 rads, doesn't cause any problem. But yes, 3 to 4 weeks, if you see 3 to 4 weeks, then spontaneous abortions can happen, although the risk is very low. And 5 to 10 weeks, there can be problems of malformations, because that's the time when the organogenesis is happening. So you know that organogenesis takes place up till 9 to 12 weeks. So 5 to 10 weeks, if there's an exposure, then there's a possibility of malformations. 11 to 17 weeks, organogenesis is complete, but all the organs are growing in size, the brain is growing in size. And if that time there's a radiation exposure, the baby may have decreased IQ. 18 to 27 weeks, IQ defects only if the exposure is much more than what is the safe dose. And beyond 27 weeks, nothing much will happen when we do the radiation at diagnostic doses. So that's the list. Let's move on to question number 2. Which of the following is not indicated in the first trimester abortions? I think the question more precisely should read that which of the following methods is not done for a first trimester abortion. So yes, a DNC is a very good tool, a dilatation curettage. That's the, if the baby is very small, like it's a 7-week, 8 weeks baby, then you can use a curette to take that baby out by a gentle curettage. You can get that baby out, whether it's a live baby or for an MTP or a dead baby which you need to take out. Either way, small curette we can take out with a DNC. So that is correct up till 12 weeks. But remember, after 12 weeks, if you're taking out a baby with instruments, then that is known as dilatation and evacuation. Before 12 weeks, we call it dilatation and curettage, simply because after 12 weeks, the baby is very big. I mean, the limbs are formed, the bones are formed, so you cannot just curette the baby out. So after that, we call it dilatation and evacuation. Before that, we call it a dilatation and curettage. Very simple basics. And what is a, yes, DNC can be done. What is a manual vacuum aspirator? Now, this is the question which has come in the last few exams very regularly. The manual vacuum aspirator is basically a syringe of 60 ml by which we create a pressure and use a common cannula. The size of the cannula is the same as the the number of weeks the patient is pregnant. So you know that part well. But manual vacuum aspirator, please read about that. That when we use the 60 ml syringe in the OPD, you can do this abortion up till 12 weeks by manual vacuum aspirator just by giving local anesthesia, and the pressure generated is around 600 to 660 millimeters of mercury, negative pressure obviously. So we can also do the misoprostol and the mifepristone method. That is the medical management of an MTP in the first trimester. Up till 7 weeks, it is 99% successful. Up to 9 weeks, it is 95% successful. India, it is recommended that you should do till 7 weeks. It's not that you cannot do for 8 and 9 weeks, but it's recommended that we do the medical abortion in the early pregnancy up to 7 weeks. But yes, ethacridine lactate is a problem because ethacridine lactate cannot be used in the first trimester. It is basically ethacridine lactate is antiseptic which causes irritates the myometrium and causes contractions. So you should give it extra amniotic. You know what's the meaning of extra amniotic? So if you see that there's a pregnancy here and this is the gestational sac, antiseptic rather, extra amniotic here. You will use some catheter which will be inserted beyond the cervix. Once it goes beyond the cervix, then this antiseptic is put into the extra amniotic space, and that causes myometrial contractions because it causes the mast cells to release the prostaglandins. So extra amniotic ethacridine lactate, you can also give it intra-amniotic also. So I have used it a few times during my MD days. Now we have much better methods like prostaglandins. Prostaglandins are the best method of second trimester abortions. Or you can use laminated 10 to dilate the cervix. Much better methods. This ethacridine lactate and this hypertonic saline, these are known to cause many more complications. So that's why it's not a very favorite method of doing abortions after 12 weeks. But anyway, it's not that we don't do them. So ethacridine lactate is a method which is used after the first trimester. Second trimester abortions are done by this. Of course, needless to say that all of you know very well now that the abortions can be done up till 24 weeks. That also has an implication on the level 2 ultrasonography. Remember, we used to do a level 2 scan, the TIFA scan, targeted scanning for the fetal anomalies, isn't it? So that scan we used to do around 18 to 19 weeks because abortions could be done only till 20 weeks. So now that the abortions can be done till 24 weeks, most people are doing the target scanning around 20 to 23 weeks. So better for us that if there are some abnormalities or anomalies which were missed when the fetus was young, so we can see them more clearly around 20 to 23 weeks. And since the abortion date, the time which we can do abortions has been pushed up to 24 weeks. So yes, because of that, even the targeted scanning has been pushed further. All right, let's go to question number 3. Simple question. Identify the image given below. So it's a placenta with a big lobe and another lobe which is next to it. Doesn't look like a succinsurate lobe because accessory lobe or a succinsurate lobe is much smaller. So this looks more like a bilobed placenta rather than a succinsurate. So I will go for a bilobed placenta. And a bilobed placenta, fairly simple. Yes. A succinsurate lobe, the lobe will be much smaller, like I'm showing you in this picture. So yes, succinsurate lobe, actually what happens that you take out the placenta by a, controlled contraction. You take out the placenta and you check the placenta for completion and you're very happy that yes, you've taken out the placenta completely. But the small lobe may stay back and cause, yes, a retained bits of placenta kind of picture. Retained bits of placenta, causes secondary PPH. And the treatment of that secondary PPH happens after the first 24 hours up to 12 weeks. So yes, this succinsurate lobe can present with a secondary PPH, and you know that secondary PPH presents after 24 hours till 12 weeks, and the treatment of that is a curettage. Okay, a retained placental bit is taken out by curettage. A retained placenta, a complete placenta retained is an emergency. You will not leave this patient and go out and think of coming later and taking out the placenta. Once the baby is delivered, if the placenta is not delivered beyond 30 minutes, then we take the patient to the OT and do a manual removal of the placenta. So, retained placenta, manual removal, retained bits, you do a curettage. Now, this one is a battledore placenta or the marginal insertion of the umbilical cord. So, if you see the umbilical cord, generally it should be inserted somewhere here. Here is the insertion of the umbilical cord, but now the umbilical cord is inserted here. So, this is known as a marginal insertion also. And this marginal insertion placenta, when you're trying to do a control contraction, this cord may snap out. It may just break from this attachment at these sides. So, that's the battledore placenta. And this is circumvallate placenta. You can see that the placenta is a little smaller, the placenta is a little smaller, and that the membranes, see the membranes are attached in the periphery as they are doubled up on the periphery of the placenta. So, when they are doubled up, on the periphery of the placenta, on the circumference of the placenta, we call them a circumvallate placenta. Basically, it means that the chorion, the placenta, chorion is placenta. The chorion is smaller than the amnion. Amnion has been made in the normal amount and the chorion is smaller. So, the membranes fold on the periphery. Circumvallate placenta associated with the, yes, it can be associated with an IUGR, also with an abruptio placentae. Okay. There are some questions on abruption further on in this list of MCQs today. Next question: what is the right sequence of the events of labor? Now, that's a very simple question. There are 7 cardinal movements of labor, and they start from the baby's head getting into the pelvis, and then getting into some flexion, descent. So, all those movements, the cardinal movements of labor, we must know them very well. So, yes, engagement is the first thing to happen, and then is the other events which come, but here they are not all the events here. So, engagement is first, definitely, and then in these things which we have been given, the next should be crowning, and the third would be restitution here, and fourth would be external rotation. So, 1, 4, 2, 3. Is there a 1, 4, 2, 3? Yes, there's a 1, 4, 2, 3. I mean, the few things which are given here, they are in this order. But yes, all of that is basically in this order. So, first the head gets inside, that's engagement, then there is ongoing descent, and there will be flexion. Always flexion is there in a baby's head, but there is still more flexion when the head goes deeper into the pelvis. So, engagement, descent, flexion, and then internal rotation. Now, this is always ours. It happens at the level of the pelvic floor. It happens at the level of the pelvic floor, which is known as the levator ani, which is the best support of the uterus. Levator ani is the best support of the uterus, and that is the place when the baby's head is gone into the pelvis. The head hits on the pelvic floor and rotates. So, whatever hits the pelvic floor will rotate. That's why sometimes occipito posterior will become occipito anterior. Left occipito transverse becomes direct occipito anterior because of the rotation of the head at the pelvic floor. And then there's a delivery by extension like that. So, that is what is shown here. Yes, yeah. See here, that is delivery by extension. And then once the head comes out, whatever internal rotation had happened, the head comes out and corrects that rotation. So, correction of internal rotation is known as restitution. So, this restitution is the correction, of internal rotation is known as restitution, and external rotation is the last cardinal movement. External rotation is because of the shoulder hitting the pelvic floor and rotating. So, when the shoulder rotates on the pelvic floor, obviously the head will rotate outside. So, this is because of the shoulder rotation at pelvic floor. Alright, so these are the cardinal movements of labor. Good, simple question, but then yes, it's always good to revise these basics. They can always ask you these basics in the exams. A woman who presented with seizures at 30 weeks of pregnancy was started on magnesium sulfate therapy. Okay, they're talking about eclampsia then. What would be the first sign of magnesium sulfate toxicity seen in this patient? So, before I go into more details, please students, some of us confuse that, if sometimes at 30 weeks there is a convulsion, how can it be eclampsia? See, if a woman has hypertension and a convulsion, it is eclampsia. If woman does not have hypertension, have a convulsion, then we call it an epilepsy. Mostly in pregnancy, they're going to ask you about eclampsia. Yes, both eclampsia and epilepsy can present with a convulsion. See, convulsion is a symptom. Eclampsia is a disease and epilepsy is a disease. So, mostly in pregnancy, they're going to ask you about eclampsia. All right. So, when there is eclampsia and they give you, the treatment that they're already giving magnesium sulfate. So, what is the first sign of toxicity of giving magnesium sulfate? Please read about magnesium sulfate therapy properly. Okay. So, how do you monitor magnesium sulfate therapy and how do you see the signs of toxicity? These are all very important things of magnesium sulfate therapy. You should know the Pritchard regime. There are many other regimes which are mentioned in the books, but the current books don't mention the ancient old regimes. There are a lot of regimes which were there. When we were MBBS students, we used to read them, but even in my MBBS, which was many years back, that time itself we were told that there's only one regime which you should know properly, and that's a Pritchard's regime. And still the Pritchard's regime which is magnesium sulfate IM and IV therapy. This is the one which you should know properly. So yes, the magnesium sulfate therapy can cause toxicity, and the first sign of toxicity is a knee-jerk suppression. See, the basic level of magnesium sulfate in the blood should be 4 to 7 milliequivalents per liter. Beyond that, first is the loss of knee jerks. So I'll give you the list. So 4 to 7 is the therapeutic range, and 8 to 10 there's a loss of knee jerks, and 10 to 12 there's a respiratory depression. More than 15, yes, more than 15 causes respiratory arrest, and more than 25 causes cardiac arrest. So when there is magnesium sulfate toxicity, we always say that suppose there's a woman who is eclamptic and you've given the magnesium sulfate, you've done the delivery. Even after the delivery, you should give magnesium sulfate for 24 hours. So we should give 5 grams. The dose is in grams. Please note, not milligrams. So we give 5 grams intramuscularly for 24 hours. When you're giving the 5 grams intramuscularly for 24 hours, you must monitor the respiratory rate, the knee jerk, and the urinary output. If these are correct, if these are adequate, then only you should give the next dose. If there's a signs of toxicity like loss of knee jerks, then omit the next dose. Reassess after 4 hours and then give. Omit the next dose if any of these signs are present, especially only the first sign you should be able to see the loss of knee jerks and stop the max self. Okay. So loss of knee jerks and less urinary output should be indication enough for you to stop the max self. The next dose you should not give. Very, very careful you should be. Okay. And eclampsia is fairly common in our country. Anemia, poverty, PIH, malnourishment, all of these go hand in hand. So we see a lot of eclampsia in our country. So when you see so much of eclampsia, you should know eclampsia treatment properly. So once the patient has loss of knee jerks and there's a reduced urinary output, don't give the next dose. Definitely don't wait for these things to happen. You should see this loss of knee jerks and don't give the next dose. All right. So if there is a max self toxicity, what is the antidote? So the antidote is calcium gluconate given 10 ml of 10% solution over 10 minutes intravenously. Right. Identify the image given below. Now that they should have given you more information. Those who have not seen many such tumors might be at loss of seeing this, and I'm sure there was more information given. But this is a fairly simple one. This is an ovarian cyst with a tooth in it, and it's got this Rokitansky protuberance. On this protuberance, you can see these hair growing out. So yes, this is indeed a case of a dermoid of the ovary. This is a dermoid cyst. So don't get too confused, because once they ask you what is the most common germ cell tumor, then you should say it is teratoma. Which is the most common type of teratoma, malignant or benign? Benign teratoma. 90% of teratoma is benign, and that is the dermoid cyst. So benign teratoma or benign cystic teratoma or dermoid, they're all synonyms. So do not get confused at all. Benign cystic teratoma or benign teratoma or dermoid can all be, they're all synonyms. All right. So identify the image given below. So it's not a immature teratoma, it's a mature cystic teratoma. Why do you call it mature? When you see tissues which mature to show you some end products, like you see, you see hair, you see a tooth, you see sebaceous secretions. So it's matured into many elements. So when it is matured, you see some end of the whatever was growing new, it is showing some end to that growth. So it is called mature. Immature means there is just growth happening and you don't see any end in sight. basic pathology. So when you see, what do you mean by mature? That means you can see some end to the type of growth which is present. So that's what is there. This is a mature cystic teratoma or a dermoid, or also called a benign teratoma. Okay. Now, theca lutensis is not like this. Theca lutensis is because of high HCG. Yeah, I'll write that. It's because of high HCG. It is seen in twins and it is seen in molar pregnancies. So it is not a theca lutensis. It's because of high HCG. That is because of high HCG. Right. So answer was B to that. Let's see question number 7. Arrange the sequence of events in a dilatation and curettage. So if you're doing a dilatation curettage for whatever reason, what should you do? So yes, there are many things. You try and sound, dilatation, curating, determine the size. Obviously, you'll determine the size of the uterus first, and then you'll see the depth of the uterus. So we sound the uterus. See, this word is used so many times in gynecology, and many students, will get a little confused that what do you mean by a sound? So sound is a, metallic instrument which goes into the uterus like this, and we see it's got a handle here. So it's called the sim sound. What do you mean by sound? You put a, a small probe kind of thing into the uterus and see, and you see, okay, this is the depth of the uterus. So we are sounding the depth. Sound is, it's used as that, let me go and find out, let me go and sound him out. Sometimes you want to find out about a person, let me go and sound him out. So that's the meaning of sound. So when we want to see the depth of the uterus, let me find the depth of the uterus, I'll put a probe into the uterus. So I call it sounding the uterus. So that's how, I know it's a difficult language, it's just as difficult for me, believe me. Okay, so that's what is called the uterine sound. So determining the size of the uterus, then sound the uterus, then you do a serial dilatation of the uterus, and then you do the curating of the uterus. So yes, it'll be 4, 1, 2 and 3. So 4, 1, 2 and 3 is choice A. Question number 7, it is choice A, right? So you can see here that this is the uterus which is shown here. This is the uterus, and there is a sound here which is, there's a curate rather which has gone inside, and you're doing a scraping, and that's the speculum which is there, and this is the valsellum which is holding the anterior lip. So you're showing from the side, suppose a woman is lying down like this, they've cut the woman like this, sagittal section, they're showing you from the side. So yes, valsellum, it is to hold the anterior lip of the cervix to give you contraction, and then you put the sound, and then you do the serial dilatation, and then you do the curate. Right. So what are the indications of a curettage? You do curettage for diagnostic reasons and for therapeutic reasons. Diagnosis for, when there's irregular bleeding, or for infertility, why is the endometrium not accepting embryo to implant, and why there are some infections like tuberculosis which can be found out by doing a curettage. Therapeutic for abortion, H-mole, endometrial polyps, and even for metropedia hemorrhagica. So yes, these are the indications of curettage. I mean, you can go on adding to this list, but these are the major events which are the indications for doing a curettage. Curettage is basically the right hand of a gynecologist. When we don't understand much what you want to do for a case, after a few regular drugs and few, regular consultations, we fall back to the curettage. So infertility, do a curettage. If you want an MTP, you do a curettage. If there's too much of bleeding, do a curettage. Basically the last thing we do as gynecologists is to do a curettage. All right. Which of the following is the meaning of the term vagitus utrinus? Basically, this was a very simple recall-based question, but yes, those who have not heard of it will not call it simple. Yes, it was seen by some teachers that sometimes that when you're doing a delivery and when the head is, the aftercoming head, once you're holding the breech of the baby, when in breech delivery, especially when you're manipulating the baby and doing a delivery and the baby's head is inside and the baby reacts to all that manipulation and throws out a yell. So that is the crying sound which can be heard from inside the uterus. So I've not heard of it. I'm in gynecology ever since 1996, and it's a lot of years, 26 years, and I'm yet to hear this. So I've done thousands and thousands of deliveries. So don't take it that I've not done much deliveries, but maybe because of the noise we create as gynecologists, we create a lot of noise ourselves in the labor room. So maybe because of that I did not hear them much. So yeah, I've not heard of it, but yes, It is a well-described event. Some teachers do claim that they have heard this sound coming out from the uterus sometimes when the baby is crying. So yes, that is a cry of the fetus within the uterus. Let's move on. Question number 9. A 16-year-old girl presented to the outpatient department with web neck, shield chest, widely spaced nipples, and absent pubic hair. Streak ovaries were revealed on the ultrasound. What would be the most probable diagnosis? I think they wanted to just give you 1 mark straight away. That's why this is a straightforward question which is telling us about Turner syndrome. However simple you think this question is, please read about Turner syndrome and all the features of Turner syndrome, because it is a very common question, but just because it's common, don't forget to know the rarer features, the whole list of Turner syndrome, because there was once a question about which of the following is not seen in Turner syndrome, and a lot of you marked lymphedema. You marked as if lymphedema is not seen. Actually, lymphedema is seen in quite a few aneuploidies. You see lymphedemas. That's the the fluid beyond the on the back of the neck of the fetus. You can see on the ultrasound. That's how you see early lymphedema. That's why when you see the nuchal translucency to be more than 3 millimeters, you think in terms of aneuploidies. One of the aneuploidies is Turner syndrome. So yes, do not miss out on lymphedema, which is seen actually in Turner syndrome. I'm telling you before I give you the whole list. So what is the list? Answer is 45XO. Also, mosaics of Turner syndrome are known, but the most common is the 45XO. So it's got an absence bar body. For a bar body, there should be 2 X chromosomes. There's a short stature, web neck, cubitus valgus, underdeveloped breast, absent pubic hair and axillary hair, exaggerated epicanthic fold, lymphedema, which is seen in up to 80% of Turner syndrome. A small uterus, hyperplastic uterus, less estrogens because the ovaries are small, less estrogens, so the growth of the uterus is not good. Even whatever uterus is made, it does not have much estrogens to support any growth of the endometrium in the uterus. When there is no growth in the uterus, there will be no periods. So that's why the patient will have primary amenorrhea. One of the most common causes of primary amenorrhea is Turner syndrome. All right. There might be coarctation of aorta, deformities of digits, and gonadal dysgenesis, which I said small ovaries or streak gonads. Most common cause of gonadal dysgenesis is Turner syndrome. So yes, sometimes they'll confuse you. What is the most common cause of primary amenorrhea? You'll say Turner syndrome. Some books may also say that most common cause is gonadal dysgenesis. So it's fine, both are correct, because most common cause of primary amenorrhea is gonadal dysgenesis and most common form of gonadal dysgenesis is Turner syndrome. Fine. Question number 10. Which of the following arteries are branches of the posterior division of the internal iliac artery? So since I can see the choices are many, so more than one answer you had to give. So posterior division of the internal iliac artery. So my mnemonic which I keep giving in the classes is short gills. SG for superior gluteal, IL for iliolumbar, and LS for lateral sacral. You know that anterior division has many branches and posterior division has only 3 branches. Recently, they are not asking you this simple question. They are asking you what is the principle of internal iliac artery ligation, that you actually do not obliterate the internal iliac artery. You just put a snug ligature and you reduce the pulse pressure of the internal iliac artery and not obliterate the flow in the internal iliac artery. That's what they're asking you. But I'm happy that they've asked you a very simple question this time, and that is, what are the branches of the anterior and the posterior division? So posterior division, 3 branches. So iliolumbar, yes. Lateral sacral, yes. Superior gluteal, yes. Inferior epigastric is definitely not the answer. So yes, the answer is ABC. Answer is A then. So if you see this, internal iliac artery, you see this is the common iliac artery, and then it continues as the external iliac, which under the inguinal canal becomes the femoral here, and then there's the internal iliac, which has a posterior division and the anterior division. So the anterior division and the posterior division branches you should know, and that you should also know that in a case of internal iliac artery ligation, we are not ligating the whole internal iliac. Yes, we are not ligating the internal iliac totally. We are ligating only the anterior division here. We are ligating only the anterior division, not the posterior division. In fact, in one exam, which was an MCI exam, they asked you what can go wrong if you ligate the posterior division. That's what also has come as an exam question for the MCI students. So please, when you read about the interlinear artery, what can go wrong if you ligate the posterior division. So in fact, you should know what is the superior gluteal supplying, what is the iliolumbar supplying, and what is the lateral sacral supplying, and what can be the problem if you ligate the posterior division. Right. So that was a fairly simple question. Let's see question number 11. Which of the following methods of contraception is irreversible? In other words, all of the following are long-acting reversible contraceptives except. So, injectable contraceptive drugs are long-acting and reversible, like the injection Depo-Provera, 150 milligrams once in 3 months we give it and keep repeating that. And implants, yes, the Norplant or the Implanon, they are long-acting reversible. Sterilization is not reversible till you do a surgery and do a reversal of that. So, sterilization is not reversible. IUCD is definitely reversible. So, the answer to this question is C, sterilization. Fairly simple question. Question number 12, interesting question which came after a long time. Perimortem cesarean section is done by which of the following methods? That is, if a woman is dying or has just died in front of you, I mean, she's in front of a doctor like you, and you may not be a gynecologist sometimes. You could be just, you could be, a dermatologist, you could be an ophthalmologist, you could be a surgeon, you could be any other doctor, but you should know a basic training that if a mother is in front of you, you are the ICU doctor attending, you could be a medicine graduate, postgraduate, and you see a woman who is pregnant and the gynecologist is not there for that time for whatever reason, and you see that the mother has just died in front of you, she had an arrest. You're doing your CPR, but if you know that the baby is also is going to die because of the mother's death, then you can save the baby by doing a cesarean section very fast. So yes, you don't have to be any expert, because now you're doing a life-saving surgery for the baby. So you don't have to be very aesthetically, very good incision you have to give, and you have to give a lower segment incision so that you can, lower segment incisions are given so that next time the mother can have a normal delivery. But there's not going to be any next time here. So basically it means one slash on the abdomen to open, one slash on the uterus to open the baby and take the baby out. So that's why we call it a classical cesarean section. So yes, perimortem cesarean sections are done for saving a baby, because the mother is dying or had just died in front of you. You may get around 2 to 5 minutes of time. Once the mother is dead, the baby still might be living for 2 to 5 minutes. So if you do an immediate cesarean, you do a fast cesarean, that immediate fast cesarean is done by the classical cesarean section. So yes, which of the following method? It is through the upper segment. I'm sorry, I should be marking this one through the upper segment. Okay, so the answer is C. So what is the abdominal incision? What is the uterine incision? They are two different things. How you cut the abdomen of the mother? So now the answer to this question is done. We do a classical cesarean section when there is a postmortem or a perimortem cesarean. Now, what do you mean by cesarean section? So there are two incisions which you have to keep in mind. One is the abdominal incision. Now, the abdominal incision can be two types. We can cut the abdomen like this in a vertical incision here, and this is the pubic symphysis here, or we can give a lower abdominal incision like this. When I give a lower abdominal incision like this, it is just above the pubic symphysis. So what is the benefit of this lower abdominal wall incision, the incision just above the pubic symphysis? What is the importance of this? This is cosmetically better, because if she wears an undergarment above her pubic symphysis, she can easily cover the incision. So suppose she's wearing let's say a bikini on the beach, and then she had a cesarean earlier, so this can easily cover this. The lower part of the bikini can easily cover this incision. That's why it is actually the lower abdominal incision is actually called the bikini incision or the Fannin steel incision. So this is the Fannin steel incision or the bikini incision, which we call it, because it is cosmetically a better incision. So this is the abdominal incision. Okay, the abdomen can be incised vertically, which is faster to do a little bit. But nowadays surgeons are smart enough, the gynecologists are smart enough to do a lower abdominal incision, the Fannin incision, in just about the same time. So this is cosmetically better. So abdominal incision has only cosmetic importance in modern obstetrics. This is the only reason why we give a lower abdominal incision because it's cosmetically better. Now, what is the uterine incision? Now, uterine incision, you must understand, suppose there's a fetus inside this uterus like this, and for whatever reason you want to do a cesarean section. So, you must know the anatomy of this, that this is the vaginal opening. Yes, this is the vagina here. The cervix is, suppose, say 8-9 centimeters. For some reason, you're doing a cesarean section. You must know that the bladder is at the lower part of the uterus. So, if I have to make an incision in the lower segment, the incision is here somewhere, the one which I marked in red. So, the lower segment incision is here somewhere. Why am I giving a lower segment incision? I think you know that the lower segment does not take part in labor. The upper segment takes part in labor. Upper segment contracts, lower segment relaxes. So, next time the mother with the lower segment cesarean can be given a trial of normal delivery. That's why we give a lower segment cesarean section. So, when I'm giving a lower segment cesarean section, it is better for the mother. Why? Because it heals better, it bleeds lesser, and it gives a stronger scar, and this scar does not take part in a contraction. Next time, the mother can be given a trial of normal vaginal delivery, what we call as a VBAC, vaginal birth after cesarean, only when you do a lower segment cesarean. So, lower segment incision is given here. So, what is the intricacy of this? You can cut the abdomen fan and steel, or you can cut the abdomen vertical abdominal incision, whatever. You've gone into the abdomen. Now, you have to cut at this lower segment. The bladder is in the way. So, this bladder has to be pushed down. You have to open the UV fold and push this bladder down. You know, we push this bladder down like this. Now, the bladder has to be pushed down like this. So, once the bladder is pushed down and once the bladder is here, you have to keep the bladder here. So, you'll have to put a retractor through this incision. Yes, that is a retractor which you in turns will correlate with very well. Yes, that is the Doyne's retractor. With that retractor, you have to push the bladder down, and then only you can make this incision here. This incision to take the head out of the baby. You can do that only once you can push the bladder down. Then only you can do a lower segment cesarean section. So, to do this, you need good time, you need good surgical skill to push the bladder down and then make a lower segment incision. But once the mother is dead, you have, no concern about the cosmesis of the incision or the repeat cesarean. All that is of no concern. So, you have to quickly open the abdomen with one slash on the abdomen and one slash on the uterus and take the baby out to save the baby out quickly. So, that's the uterine incision. All right. So, answer is C. C is that through the upper segment when there is perimortem cesarean section. Okay. What are the other indications? What are the other indications of doing a upper segment or a cesarean section of the classical type or the upper segment type, which we say it is bladder fibrosis. If there is a fibrosis of the bladder, then you cannot push the bladder down. Bladder fibrosis, lower segment tumors like a fibroid and a CA cervix. These are the indications for which you have to do a upper segment cesarean section or the classical cesarean section. Okay. Now, which of the following is not a risk factor for vulval cancer? Now, vulval cancer are two types. The older woman will have the keratinizing type, keratinizing, and the younger woman will have the baseloid. So, yes, the vulval cancer is indeed the squamous cell carcinoma, and in the older woman it is the keratinizing type, and in the younger woman it is the baseloid type. Yes, the younger woman will have the CA vulva because of HPV 16 association and smoking association. But this is not seen, HPV and smoking association is not seen in the women who are older and having CA vulva. So, older women having CA vulva, it is because of lichen sclerosis, squamous metaplasia, lichen sclerosis, vulvar dystrophies are the ones which are the causes of the older woman. So, this older woman having CA cervix is the more common type of CA vulva, not CA cervix. So, the older woman having CA vulva. It is the one which is the commoner type, older women, and that is classically associated with lichen sclerosis and has a lot of itching. So yes, smoking and HPV associated with younger women having CA vulva, vulval dystrophy, that is lichen sclerosis, associated with older women having CA vulva. So mostly you should remember that CA vulva, when they ask you, they'll ask you the classical CA vulva, which happens to older women around 60 to 80 years of age. Vulval hematomas are not associated. So answer to question number 12 is D. All right, question number 13. For vulval cancer, the most common age group is C. Immediately after that, I've got this question. I don't know whether both the questions came. Two CA vulva questions coming in one exam is unlikely. I think the students probably did not recall this properly, and my team gave me two questions instead. Good revision for you anyway. So good revision for you. Vulval cancer, the most common age group, because it's the older woman who is going to get more CA vulva. So that's why the most common age group I'm going to say is 60 to 80 years. So answer is D. Question number 14. An exposure to diethylstilbestrol can lead to which type of carcinoma? Now, diethylstilbestrol classically causes adenosis of the vagina, and adenosis of the vagina later on can go and cause the clear cell vaginal carcinoma. So yes, sarcoma botryoides is embryonal rhabdomyosarcoma. It is of an unknown etiology, mostly had a good prognosis, but that's not because of diethylstilbestrol. Diethylstilbestrol, classical association with clear cell vaginal adenocarcinoma, and not choice C and not choice D. Okay, so adenosis is the most common histological association with diethylstilbestrol exposure in utero, and adenosis is basically persistence of Mullerian type of glandular epithelium. It appears as red grape-like slus in the vagina, at the exocervix, or in the upper one-third of vagina. 97% of cases of vaginal clear cell adenocarcinoma associated with adenosis. So yes, most common thing which you see because of diethylstilbestrol exposure in utero is adenosis of a newborn girl's vagina, adenosis, okay? But an adenosis can later go and have a clear cell adenocarcinoma also. So answer is A. Now, question number 15. Which of the following hormone is secreted by the placenta? So there is only one of this which has got a chorion word in it. So the human chorionic gonadotropin. So if you know chorion, then you know chorion is the placenta. So human chorionic gonadotropin. So that's a fairly simple question. I think INI-CET exam is the only one in which you will get some 6-7 questions which are given to give you confidence. Okay, you got so many correct. They'll make your rank based on the other 20 odd questions which are coming in the exam. So yes, this is that easy one. HCG is from the placenta. So yes, I thought I'll give you a list of things which are important and keep coming in various exams. So if you see HCG is similar to LH, FSH and TSH. The alpha subunit is shared in LH, FSH and TSH. It's a very important biochemistry question also for you. And yes, the beta subunit is specific for pregnancy. So beta subunit is more in after around 6 weeks of pregnancy. The beta subunit is more in amount when HCG is measured. So beta subunit is more specific. So the HCG maintains the corpus luteum. It makes the male fetus, if there's a mother carrying a male fetus, then the fetal testosterone production is based on this HCG, chorionic gonadotropin. It is from the chorion and it acts on the gonads. All right. So it acts on the gonads of the mother. Mother's gonad is the ovary, which is got the corpus luteum. So that maintenance is by HCG. And it also acts on the gonads of the baby. If the baby is a male, then the testes production of testosterone is based on this, and stimulates also the maternal thyroid. You know that the alpha subunit is shared, so that high alpha subunit will stimulate the maternal thyroid to make a lot of thyroxine. So that's why the TSH in early pregnancy reduces. That's why we always ask you this question in the physiology of pregnancy. Which of the following is reduced in early pregnancy? TSH classically reduces in 80% of pregnancies, in the first trimester especially. 80% of women in the first trimester reduce the TSH. Why? Because the alpha subunit of HCG is stimulating the thyroid enough to make thyroxine. So there's a good feedback of thyroxine to the brain, and brain reduces the TSH. That's a very good equation which keeps coming in exams. Now, human plasma lactogen is similar to growth hormone and prolactin, helps in fetal energy requirements. Corticotropin releasing hormone promotes the steroid production in the mom and fetus and also initiates the parturition, but that's not a very, very clear. Parturition has so many initiating events, there's so much talk about prostaglandins. So yes, it may be taking part in the parturition initiation, and the gonadotropin releasing hormone is also released from the placenta. It regulates the trophoblastic HCG production. Right. So these are the graphs of what all I discussed just now with you. I thought you could take this picture, this from Williams Obstetrics, and you could see what all I have discussed. So HCG is high, in the initial few weeks only, around till the 66th day of pregnancy or the 9 weeks and 3 days of pregnancy. And the human plasma lactogen increase around the 30th week. It starts production around the 20 weeks onwards, but yes, it is maximum around the 30th week to 36th week. And the corticotropin release hormone also from the 30th week. So a little bit more about the human chorionic gonadotropin, since it keeps coming in your exam. Another hormone which they'll ask you in the exam is the alpha fetoprotein. Read about that also, the half-life and the weight and where is it made from, like it is made from the fetal liver, all that you should know about alpha fetoprotein. So human chorionic gonadotropin, molecular weight is around 40,000 Daltons, and it has the most carbohydrate content of any human hormone, almost 30%. And the half-life is 36 hours versus LH. See, LH is similar to HCG, but the half-life of LH is only 2 hours, but HCG is around 36 hours. So that's why when you give HCG for triggering of ovulation in IVF, it causes more ovarian hyperstimulation syndrome because the action is high for a longer time. So that's why people say give recombinant LH these days to trigger ovulation so that OHSS is lesser. Very right kind of a moment which I chose to inform you about ovarian hyperstimulation syndrome. Yes, HCG is the final trigger for ovarian hyperstimulation syndrome, and it's got a very long half-life. Compared to LH, it's got a short half-life. So that's why the incidence of LH is much higher when you use HCG as a trigger for IVF. And the chromosome 6 encodes for the alpha subunit, and chromosome 19 codes for the beta HCG and the beta LH group. So the alpha subunit and the beta subunit are from the two different chromosomes, and then they integrate and make the HCG. Till 5 weeks, syncytioblast and cytoblast both make HCG, and after 5 weeks, syncytioblast alone makes the HCG. So maximum, like I told you, it's at the 66th day or around 9.5 weeks, and HCG molecule is detectable from 7 to 9 days after the mid-cycle LH surge. What is the meaning of this? That when the LH surge happens, after the peak of LH surge, there is ovulation, and implantation after ovulation, suppose the lady has intercourse, then the implantation happens on the 6th day. So after ovulation, 6th day is the day of implantation. So from the day of LH surge, 7 to 9 days. See, 7 to 9 days. LH surge happens roughly around 12 hours before the ovulation. So from ovulation, 6 days implantation, 7 day you can see the HCG. So here they are saying HCG is detectable 7 to 9 days after the mid-cycle LH surge. That's what is done by the radioimmunoassay. Very sensitive. Even on 7 days after ovulation, you can find out that the HCG is high, and you can say that the woman is pregnant. Radioimmunoassay is the method by which you can see this HCG as early as 7 days after the mid-cycle LH surge. We'll take next question. All are true about the late deceleration except it starts with or after contraction but ends out always after contraction, symmetrical and wide, more than 10 to 20 beats from the baseline, variable and short. I think I'll just tell you the answer, because variable is variable deceleration, as simple as that. I don't know whether these were the choices. I mean, this is a straightforward answer here. Variable deceleration is because of umbilical cord compression, and variable deceleration is the most common deceleration. Okay. Now, late deceleration is because of placental insufficiency, and early deceleration, is because of head compression. So let us talk about late deceleration. Now, the late deceleration Yes, answer is to this question is D. Variable in short is not associated with late deceleration. So what is late deceleration? Now this is, I've got you a late deceleration picture from my hospital. So if you see this, this is the fetal heart rate, which is showing a deceleration. There are two decelerations here. So if you see this, these are the uterine contractions here. So that's why we call it the CTG, cardiotocography. So whose cardio I'm worried about? The fetal cardio, you know, though this is the cardio part, the fetal heart rate part here, and the uterine contraction part here. So when you see the peak of contraction, that's what they're saying, you see the heart rate going lower much later. It's not coinciding. If it is coinciding, we call it early deceleration. If the heart rate is taking time to go low, we call it a late deceleration. So late deceleration is a smooth, gradual, symmetrical decline of fetal heart rate. Smooth, S is slightly not visible here. It's a smooth, gradual, symmetrical decline of fetal heart rate, begins at or after the contraction peak. See, this is the contraction peak, and after that only, see, this is late, you know, it is late deceleration. Here again, late deceleration. Begins at or after the contraction peak and returns to baseline only after the contraction ends. See, the contraction has end. After that only it is going back to the baseline. See, contraction has end. It has gone to the baseline only after that. So the depth is 10 to 20 beats from the baseline. Roughly we say 10 to 20 beats here, but we should, if they ask you an ideal, then an acceleration is 15 beats rise from the baseline. A deceleration is 15 beats drop from the baseline. That is what you should say if they ask you exact number to say what is an acceleration and deceleration. So rise of fetal heart rate 15 beats from the baseline and drop of fetal heart rate 15 beats from the baseline. Okay, that is acceleration and deceleration respectively. So the decrease in fetal heart rate is calculated from the onset to the nadir for 30 seconds or more. From the onset to the nadir. Nadir means the lowest anything is known as a nadir. Peak is the highest anything. So cause of the late deceleration are maternal hypotension like after an epidural, excessive uterine contraction if you give too much of oxytocin, and placental dysfunction which can be seen in hypertension and diabetes mellitus. And also this can be seen in abruption, this late deceleration. Alright. Question number 17. All of the following are seen in abruptio placentae except, mind you, sometimes they will not say abruptio placentae, they will say accidental hemorrhage, which is a synonym. Okay, Britishers call it accidental hemorrhage, Americans call it abruptio placentae. Indians are the best. We teach you abruptio placentae. In the exams, we sometimes ask you accidental hemorrhage. Never mind, it's happened once, long time back when they asked you accidental hemorrhage. So, all of the following are seen in abruption except uterine tenderness, yes. Increased uterine tone, yes. Painless bleeding, classically associated with placenta previa. So, this is not seen, and abdominal pain is seen. So, there is bleeding into the uterine muscle. That's why there is this uterine tenderness. You know, we keep saying tender uterus, but we never know why that uterine tenderness is there. So there is this placenta, and this is the umbilical cord attached to the baby, and this placenta is having some bleeding, retroplacental bleeding is happening. It could be concealed or it could be coming out like this, revealed. So it could be concealed or revealed bleeding. Sometimes the bleeding is into the uterine muscle. So when there's the bleeding into the uterine muscle, there is bruising of the uterine muscle. So bruised uterine muscle, like any other bruise, you know, if you get socked, if you get hit on your arm and somebody hits you very hard, you have a hematoma here. So it'll hurt you for a long time. Just like that, if the uterus is bruised, it'll hurt the woman, you know, it'll be a painful contraction. And if you palpate the abdomen, it'll be tender. So tender, painful, bleeding is abruptio placentae, classically associated with hypertension. Also seen in smokers and drug addicts, but classically associated with hypertension. All right. Now, the answer to the previous question is C. Now, question number 18. This is the only question which I gave with a white background. You know, before I read this question, I must tell you this. Thanks to this INI-CET exam and the AIIMS exam especially, every year, one or two controversies which keep coming in our discussions as gynecologists get sorted out. And this is that one question this year. this question has sorted out that one very important controversy which is there with what I'm teaching in, which is there in so many other places where you keep hearing, something else, especially from WHO. When you hear that WHO says don't do uterine massage, and I keep shouting hoarse that please do uterine massage if you're a gynecologist. See what they're asking you. They're asking you what are the events after delivery, and they want you to write the events in the right order, and uterine massage is part of that order. All right. So yes, uterine massage is very much the part of management of active management of third stage of labor. Okay. Before I tell you the answer for this question, uterine massage is part of third stage of active management of third stage of labor. Okay. Arranged in sequence for third stage management. Yes, moment the baby is born and you have to now take out the placenta. Before the active management of third stage, make sure that there's no second baby inside. So mostly you would know that because you will be doing antenatal care, but check for the second baby and give oxytocin 10 units. You can give it intramuscular or intravenous, and then do a control cord traction. And after the placenta is out, give a gentle uterine massage. Yes, you should not give sustained uterine massage. It will be painful. A gentle uterine massage is a habit with a gynecologist. Moment you do a control cord traction and the placenta comes out, you keep the placenta, for examination later, but immediately you put your hand inside the vagina, one hand on top of the abdomen of the mother, and give a gentle massage to the uterus. That massage will help in uterine contractions. So it is part of the active management of third stage of labor. So yes, answer is indeed A, B, C, and D. So this is the answer for this question, question number 18. All right, question number 19. All are non-contraceptive health benefits of combined pills except oral contraceptive pills. Basically, I'm sure they wanted to ask you combined oral contraceptive pills, but let's see. Reduce risk of ovarian cancer, yes. What is the main cause of ovarian cancer? It is epithelial injuries. What are the epithelial injuries? Ovulation is the epithelial injury. So incessant ovulation, non-stop ovulation is the cause of a woman having injury to the ovary, and early menarche, late menopause, and nulliparity, no break from ovulation, or a woman who is at IVF treatment where we make a lot of eggs every cycle, 15-20 eggs in an IVF cycle we make sometimes. So too much of ovulation, incessant ovulation. When you give contraceptive pills, there is no ovulation. So that's why ovarian cancer is less. Similarly, reduced risk of endometrial cancer. Yes, if you give combined pills, what I've taught you in the classes, that when you give combined pills, the pituitary gets suppressed. So LH and FSH is not made. So the ovary is not working. Ovary is not making a follicle and not making a corpus luteum. So there's no estrogen progesterone from the ovary. So the only estrogen progesterone which is present in the woman's body, the maximum estrogen progesterone which is present in the woman's body, is because the pill which I'm giving. The ovary is suppressed and the pituitary is suppressed. So the only estrogen and progesterone in the woman's body is from the tablet which I'm giving. And I'm giving low dose OC pills. Remember, low dose pills we give. So that's why the amount of estrogen in the woman's body is low, not high. When I give combined pills, there is less estrogen and less progesterone in the woman's body. And when there is less estrogen, there is less proliferation of the endometrium and less endometrial cancer, less menorrhagia, less anemia. So many wonderful benefits are there of combined pills. So yes, there will be reduced ovarian cancer, reduced endometrial cancer, reduced ectopic pregnancy. Correct. When the woman doesn't get pregnant, she obviously reduces the numbers of ectopics also. So ectopic is less, but STD and HIV, there is no benefit. So obviously there is no benefit in HIV control. And yes, there is some STDs might be lesser, but chlamydia increases. And HIV, there's obviously no benefit because sexual intercourse without any protection can cause HIV. So just banking on combined pills is no benefit for HIV. So yes, the straightforward answer to this question of 19 is C. Ectopic pregnancy, like I said, that pregnancies are lesser, so ectopics will also be lesser. Don't say combined pills or progesterone only pills causes more ectopics. That's a wrong notion. Okay, pregnancies are lesser, so obviously ectopics will be lesser when you give combined pills or even progesterone only pills. Right, so the answer to this question number 19 is C. Okay, let's move on and see question number 20. Which is wrong about normal placenta? A very basic kind of a question. Weight is 500 grams at term. Yes, we know that. and diameter is around 20 centimeters. It is thickest in the center, and it has membranes with 2 blood vessels. No, that is wrong. It has a umbilical cord with 3 blood vessels. 3 vessel cord is normal, and that is one vein. The vein is carrying the oxygenated blood in the umbilical cord, and there are 2 arteries. Yes, to begin with, there are 2 veins and 2 arteries, and the right vein gets obliterated, and the left vein is left behind. Left vein is left. So the left vein, which is left behind, is the one which is carrying the oxygenated blood to the fetus, and the arteries are taking the deoxygenated blood from the fetus towards the placenta to get oxygenated. All right, and thickness is around 2.5 centimeters. Like I told you, it's thickest in the center, and umbilical cord length is around 50 to 60 centimeters is the average length. But yes, what is the short? What is the short umbilical cord? Short is less than 20 centimeters, and a long umbilical cord is more than 300 or 3 meters, 300 centimeters or 3 meters. All right, so average length is around 60 centimeters. So answer to that question is C. Let's go to question number 21. The signs seen by 8 weeks of pregnancy are, multiple choice answers here. So 8 weeks, you'll see the Goodell sign. Yes, Goodell sign is softening of the cervix, and Osiander sign is the pulsatility. Pulsatility in lateral fornix of the vagina. Fornix. What's the fornix? I'll show you the lateral fornix. So if you see the vagina here, this is the vaginal opening, this is the cervix. So this area here, this area is known as the fornix, the lateral fornixes. So Osiander sign is the pulsatility. When you do a per-vaginal examination and put your fingers, this is the uterus, and this you do a PV, and you go laterally, on the sides of the cervix, fornices, you will feel some pulsatility. So that is what is Osiander sign. Lightening is, of course, the head getting into the pelvis engagement, and the woman feels lighter. The baby is all stretching the abdomen, but moment the head goes into the pelvis, baby, major part of the baby is gone into the pelvis, so mother feels a little light. So that is what is called lightening when engagement happens. And internal ballottement, that is, if you put your fingers in the vagina and hit the head of the baby gently, the head will go up and come back and hit you on the finger. Internal ballotment. So these two are not seen in the early pregnancy. Early pregnancy, you'll see A and B. So yes, softening of the cervix and pulsatility in the lateral fornix, that is A and B. Answer is A. What is softening of the isthmus? Softening of the cervix is Goodell sign. Softening of the isthmus, here, this is the isthmus here, the area between the anatomical and the histological internal os. So area between the anatomical and the histological internal os, that is known as the isthmus in the cervix. So isthmus, softening of the isthmus, soft isthmus is the Hagar sign. So whenever I teach you in the physiology of pregnancy science, I always tell you these signs, and we generally see Hagar sign coming as a common MCQ, but this time they asked you Goodell's and Osiander's. Chadwick sign is also another sign which came in the exam once. It is the bluish discoloration of the cervix and the vagina around 8 weeks again. So answer is A. We'll take now question number 22. As per Anemia Mukt Bharat Abhiyan, how is mild to moderate anemia treated in pregnant women with gestational age 34 weeks? So, they've asked mild and moderate both. I doubt if this was the question, but I'll try to give the answers nevertheless. Now, when there is Anemia Mukt Bharat guideline seen, we generally say that always start oral iron therapy, and if there is, we start double the dose. Generally we give 60 milligram 1 tablet, so we make it 2 tablets a day. So we generally double the dose, but mostly this will do. But what happens that when you give oral iron therapy, then even if you give injectable iron therapy, the rate of rise of the hemoglobin is around 2 to 3 weeks, it will increase 1 gram of hemoglobin. So late in pregnancy, maybe she cannot eat so much of so many tablets, or maybe she might not be so compliant. So it's better that you keep her, tell her to keep coming to the hospital and you give her injectable iron. So that's the logic behind this. Moderate anemia at least. Mild anemia also, they say, if people in our country, they don't listen to your orders so easily. They don't come to the hospital. So if you give them the information that you need injectables and you're going to be very sick, then they may actually follow up. And they may sometimes, even if they don't eat tablets, they'll listen for taking the injections. So with that logic, the answers are given to this question. So I would say that at 34 weeks, which is late in pregnancy, I would go ahead and mark according to the program. Okay, according to the program, I'll go and mark IV iron sucrose only, because never ever combine oral and iron therapy. You know that when you give oral and IV iron therapy, the site of absorption of iron is still the gut receptors. So if you're giving, suppose this is the gut and there is iron given orally, so it is absorbed by the gut receptors here. But if you give it into the buttocks, suppose you give it intramuscular. So if you're given it intramuscular, suppose this is the gluteus maximus, and if you're given the iron here, now this also, if you give, it'll go through the circulation and get absorbed from the same receptor. So iron is always absorbed by the same gut receptors. So if you give oral iron, it'll go and saturate the gut receptors. It'll go and occupy the gut receptors. And then along with that, if you give the injectable iron, it's not going to get absorbed because the gut receptor is occupied by the oral iron. So if you give both together, then there will be iron overload in the body, and this excess iron will go and get deposited in the liver. So that's why don't give oral iron and injectable iron, or parenteral iron like we call it, together. So this can definitely not be the answer. Okay, B is wrong. So oral iron folic acid tablets, I would have said that is a better answer, but then yes, very clearly they have written that in Anemia Book Bharat program, late in pregnancy may be the first line for anemia late in pregnancy. So because of this guideline which is given, if you can go ahead and see this, web address which I've given you, I'll try to give this in the, the information below this YouTube video also. So you can go and see this link. In this, they've given that if it is late in pregnancy, it's better that you offer the injectable iron. Not that the rate of rise of hemoglobin will be faster. There might be compliance issues. So it's better to give injectable iron, and you can give a total dose iron infusion also. That is also one benefit of giving injectable iron. The rate of rise might not be very fast. It will not be faster than the oral iron, but you can give the total dose infusion in this one shot, or you can give a lot of iron on daily IV sucrose basis. You can give it over 1 week, a lot of iron. So that's why injectable iron might be more better compliance wise. That's why they say anemia late in pregnancy, better you give the parenteral iron. So that's why my answer is this. So for question number 22, I will answer IV sucrose only, or iron ferrous carboxy maltose. You can give both of these, any one of these. Now, it cannot be managed with diet alone. Any woman who is pregnant, please, I wanted to stress on this part. So this is also wrong, because any woman who is pregnant, please give oral iron therapy after 12 weeks, because no amount of dietary iron will be able to match the requirement of iron in pregnancy. Please remember that. So whatever oral iron you give, the best source is meats, and you give meats 3 times a day, still the iron tablet is required in pregnancy. So that's why manage with diet. The iron deficiency never can be the answer. Not for even a normal woman. For an anemic woman, definitely not. Even for a normal woman, you must give, a woman with a normal hemoglobin, you must give oral iron supplements after 12 weeks. So this is definitely not the answer. Answer is A. Okay. Question number 23, which is not a component of the biophysical profile. Now, that is very simple. Biophysical profile is the non-stress test and the fetal movement, fetal tone, fetal breathing, and the amniotic fluid index. These are the 5. And this is a very simple question. I'm not going the great details. Daily fetal movement count is not. Daily fetal movement count, that is the Cardiff count of 10. We also call that the Cardiff count of 10. You tell the mother to count the number of movements in a day, especially when she's had a meal, breakfast, lunch and dinner. After that, you tell her to lie on the left lateral or the right lateral position and then count the number of movements. So, if the mother counts more than 10 movements in the 12 or 14 waking hours, that's a healthy baby. So, yes, at least 10 movements, Cardiff count of 10 we call it. So, that is not part of biophysical profile. Fetal tone is NST, amniotic fluid index is, and fetal movements are fetal movements seen by the ultrasound, not felt by the mother. Daily fetal movement count is a test which is done by the mother. So, don't confuse this fetal movement with the daily fetal movement count. Daily fetal movement count is a number of movements counted by the mother after a major meal. So, more than 10 movements is a good daily fetal movement count. That's not part of biophysical profile. While doing an ultrasonography, you see an active fetal movement. That's what is part of biophysical profile. So, fetal tone, NST, amniotic fluid index, fetal movement and the fetal breathing. Now, babies don't breathe in utero, babies are surrounded by liquor, so they cannot breathe. So, they are swallowing the amniotic fluid. Every time they swallow the amniotic fluid, it's like, see, the chest expands. Every time we also swallow, a chest expands. I exaggerated my swallowing to show you that. But yes, every time we swallow also, our chest will expand a little. So, you can put an ultrasound probe on the, mother's abdomen and see through the mother's abdomen, the side of the chest in a, sagittal section. And in that, you can see the chest expanding once in a while. That is because the baby is swallowing some amniotic fluid, not that the baby is breathing. Okay. Right. So, answer is A. What is modified biophysical profile? Modified biophysical profile is non-stress test plus amniotic fluid index. This also keeps coming in your exams. All right. We'll take the next question. Question number 24. Match the following. Now, I've not got the question properly, and I think only 4 were asked, but there's a 5th one also which came as choices on some other, I think on PrepLadder forum, students were telling that this question also had come. So, I think I'll just tell you that forget the matching. I'll just give you the answers. Thalidomide causes phocomelia, isotretinoin causes microtia, chloramphenicol gray baby syndrome, warfarin causes depressed nasal bridge, and lithium causes Epstein's anomaly. So, whatever question came, I'm sure you can, this was fairly simple question. We'll see question number 25. All of the following can cause a non-immune hydrops except, now hydrops fetalis, fluids filling up in the third space of the baby, that is pleural effusion, pericardial effusion, ascites and edema of the skin. So, fluid in the third space is hydrops, and that is basically because of non-immune causes more, 90% of hydrops, okay, NIH, non-immune hydrops, 90% of hydrops fetalis. And there's also immune hydrops, which more commonly, more regularly you've read about immune hydrops, RH isomerization causing hydrops fetalis. That's only 10% cases of hydrops fetalis. Majority of hydrops fetalis is because of the non-immune hydrops. There are 53 causes. I'm not telling you, don't worry. But please remember, the most common causes of non-immune hydrops are the cardiac causes, and in cardiac the most common is congenital heart block. That's the most common cause of hydrops fetalis, congenital heart block. Okay, so yes, there are infectious causes like the parvovirus infections, of course, herpes simplex virus, rubella, and toxoplasma also known to cause, but HIV is not known to cause. Thalassemias can cause. Alpha thalassemia causes HP Barts, which is hydrops fetalis. They can be genitourinary causes like a posturethral wall. They can be renal problems like a polycystic kidney. There are many problems which can cause hydrops. Even cystic hygroma of the newborn is a type of a hydrops fetalis. Okay, so answer is C. Which is the usual timing for this procedure when this can be started? So, we've written that there's an amniotic fluid and the needle is stopping here in this amniotic sac. So this is an amniocentesis. So amniocentesis, yes, 10 to 13 weeks you can do a chronic villus sampling. 16 to 18 weeks you can do an amniocentesis. 18 weeks onwards is what you can do the chordosynthesis. So yes, after viability of the fetus, no, that's too late. Amniocentesis can be done 16 to 18 weeks. So yes, if first trimester some of your screening tests like a dual marker is positive, then we don't abort, we do a confirmatory test. So first trimester confirmatory test is chronic villus sampling. Second trimester you're doing a triple marker and it is positive. Then what is the confirmatory test? That is the amniocentesis. That's how you remember them. Okay. Right. So question number 26, the answer is B. All right. Question number 26, answer is B. Question number 27, recombinant HPV vaccine is based on which viral protein? So the human papillomavirus, it causes its problems because the E6 and E7 protein. So that's not the answer. We use the capsid, the viral capsid to make the vaccine. So the viral capsid L1, this is the one which we use. So the major capsid protein L1 epitope of the HPV 6, 11, 16, 18, 31, 33, 45, 52, 58, all 9. These are used in Gardasil 9 now, and against this viral capsid, the HPV vaccine is made. So this is the vaccine fundamental. That vaccine is against the L1 epitope. But please remember the actions of human papillomavirus, how it causes the malignancy. It is through the E6 and the E7 proteins. E6 and the E7 protein. I don't know whether you can see that. I've written HPV acts through the E6 and E7 proteins which inhibit the tumor suppressor genes P53 and RB respectively. E6 suppresses the P53 and E7 suppresses the RB. So tumor suppressor genes, if they are suppressed, then tumor proliferation can start. That's the meaning of this. So one information which I wanted to give you, that I'm not saying that don't give the HPV vaccine, but be a little careful. HPV vaccine, Gardasil, there was a Gardasil 4. It was only against 4 serotypes. Before that, there was a Cervarix. Cervarix is against only 2 serotypes. So Gardasil 4 came because 2 was not enough. Then Gardasil 9 has come because 4 was not enough. Now, there are another 50 odd serotypes which can cause CS cervix. So please be careful. Please remember that Gardasil 9 will prevent CS cervix if you give it before exposure, and that too only against these 9 serotypes. Please, it is not guaranteeing prevention of CS cervix. Don't say that it's going to prevent CS cervix totally. No, it is going to prevent CS cervix from these 9 serotypes. It's not going to totally take away the chance of CS cervix. There are so many other serotypes. So yes, the common serotypes are taken care of by Gardasil 9. So that's why we say give the vaccine if you can afford it, give the vaccine, but continue the screening programs of CS cervix, the screening with pap smear and whatever the method you want to do. Continue the screening. It's not that the patient will not get CS cervix, surely. 9 major serotypes against which we give that protection we have, but it's not totally foolproof vaccine. So that's why we say something is better than nothing. That's why the SAGE guidelines came in the NEET exam. What are the SAGE guidelines? That give 9 to 14 years, at least give 1 Gardasil injection to these young girls. So there will be some protection against CS cervix, because after 15, 16, many girls get sexually active. So all girls 19 to 14, give this vaccine at least once so that there is some protection against CS cervix. That's why the SAGE guidelines came out. I like those guidelines. They're very practical, that at least one you give, there is some protection. There's no sure shot protection. Okay, please remember that. Okay, question number 28. A 28-year-old primary graduate presented at 35 weeks for regular checkup. On examination, her blood pressure is very high, 170 by 110. Dipstick is showing +3 protein. I think that was not mentioned here. Proteinuria, +3 proteinuria, that's high, because 1+ is proteinuria, 2 + 3+ is severe proteinuria. So there is severe proteinuria, blood pressure is high at 35 weeks. So this gets into preeclamptic toxemia. You know, blood pressure higher than 140/90 is hypertension pregnancy, and proteinuria is preeclamptic toxemia. And yes, it is still very much part of the definition that proteinuria is part of the definition of preeclamptic toxemia. And when there is convulsion, we call it eclampsia. So please remember that when there is a patient who's got high blood pressure and severe proteinuria, she is just one step short of an eclampsia. So when there is a stage like this, try to prevent the convulsion. What is the disease we are talking? Pregnancy-induced hypertension. So there is high blood pressure. Next, there is proteinuria. Next, there is convulsion. So the convulsion is because of the pregnancy. Hypertension because of pregnancy, and the convulsion is because of the hypertension. So basically, what is the cause of the convulsion? The pregnancy is the cause of eclampsia. So yes, to prevent eclampsia, take out the pregnancy. That's why I remember pregnancy-induced hypertension. That is what going to lead on to eclampsia. So take out the pregnancy to prevent eclampsia. So when you get into a stage like this, which is imminent eclampsia, severe hypertension, about to throw a fit, take out the baby, prevent the woman from having a convulsion. So that is what is the management here. Terminate the pregnancy immediately by cesarean? No, that's not required. You know, she's not yet thrown a fit or something like that, and it's still 35 weeks. So yes, I will not say immediate cesarean section. Give steroid and induce at 37 weeks. No, can't wait that long also. That is also wrong. 2 weeks is too long because she's in imminent eclampsia, about to throw a fit. Start magnesium sulfate and initiate termination of pregnancy. That seems like a good answer. Let's see the fourth choice. Increase antihypertensive drugs and do conservative management. That definitely is not the answer. So yes, once she's in a situation where there is imminent eclampsia like this, there is severe proteinuria and blood pressure is more than 110 diastolic, along with, you know, I don't know whether those choices were there here in this question, but headache, nausea, vomiting, blurring of vision, exaggerated knee jerks, epigastric pain because of a subcapsular hematoma, all of this is part of imminent eclampsia. So when the woman is about to throw a convulsion, wait. When a woman throws a convulsion, what do? You give her Maxilf and do the delivery, cesarean or normal, whatever is appropriate. When she throws a convulsion, what do? You give Maxilf and you do the delivery. Why? Because the most definitive management of eclampsia is termination of pregnancy. So what do? You take the baby out. Now the situation is she's about to throw a fit. So you won't wait for the fit to happen. You will terminate the pregnancy even in this situation. Imminent eclampsia also the management is same. Give Maxilf and plan the delivery very, very early. So initiate the events of delivery. That is, if it is a favorable cervix, I'll do a normal delivery. If it is unfavorable and the induction is going to take time, I may do a cesarean. But yes, give Maxilf and plan the delivery. So answer is definitely C. Okay, start Maxilf, initiate termination of pregnancy. All right. So what is question number 9? That's the simple question which has come many times in exams. What is the minimum number of antenatal visits recommended for pregnant women? So I don't know whether they want to ask you about WHO every time when this question comes, because in our country we say at least 4 visits. So I will say 4 is my answer, because we say 1 in first trimester, 1 in the second trimester, and 2 in the third trimester. At least 4. So at least 4 visits in India, then we say the patient may not have much problems in pregnancy. So 4 antenatal visits. But they ask you the WHO model. WHO model says there should be at least 8 visits, ideal visits. So if they ask you WHO specifically, then I would say 8. Otherwise, minimal antenatal visits in our country is 4. All right. So answer is A. So those were the questions which I thought I should be discussing with you, around 29 of them. And there were some other questions which I did not get the choices well, but I don't know whether they were questions from pharmacology, too many of them. And I'm sure the pharmacology doctor has taken very good discussions on them. Anytime, if you have any doubts about anything, you know, related to pharmacology in pregnancy or the microbiology in pregnancy, go ahead and ask me those questions. I'll be the happiest to answer to you. If you can get back to me at Dr. Prassan at yahoo.com. but you can also get back to me on the PrepLadder forum. All right. So those were the PrepLadder students. You can meet me there. Otherwise, all other students can message me on this one. So I hope you got all of these right, and the results are already out. So I'm sure this will be a good practice for those who are still waiting to write the PG entrance exam in March. May God bless you. Do very well. Thank you.